Muy buenos días y muy bienvenido al webinar de la OPS del Día Mundial de Diabetes. Good morning and welcome to the PAHO webinar for World Diabetes Day. This webinar will be in English and in Spanish. Este webinar será en español y en inglés, and we have simultaneous translation for you. At the bottom of the screen, you'll see a globe, and if you click on the interpretation globe, you can select the language of your choice. Así que yo soy Silvana Luciani. I'm Silvana Luciani from the NCD program here at the Pan American Health Organization, and I'm honored to join the International Diabetes Federation, WHO, and other organizations in this annual call for global action to prevent and control diabetes, a disease that affects millions of people worldwide. And this year, we are having a particularly important celebration as we commemorate 100 years since the discovery of insulin, a life-saving medication for many of those with diabetes. But we're also commemorating World Diabetes Day in the context of an extraordinary circumstances of the COVID-19 pandemic that continues to ravage most of our countries. So it's appropriate for this year that we celebrate World Diabetes Day with the theme of improving access to diabetes care. If not now, when? And so to deliver our message for this World Diabetes Day, we will hear from the PAHO Assistant Director, Dr. Jarvis Barbosa. Welcome, Dr. Barbosa.
Thank you, Silvana. Good morning. It's given me a great pleasure to open this webinar today to commemorate World Diabetes Day 2021 and to lend my support to this year's theme on increasing access to diabetes care in the region of the Americas. I also want to thank our partner, the International Diabetes Federation, for co-hosting this webinar with PAHO. We are all too aware that diabetes is a growing public health problem. Globally, the number of people with diabetes quadrupled in the past 40 years, and it is anticipated to affect more than 500 million people by 2030. In the Americas alone, 62 million people are living with diabetes, which is mainly type 2 diabetes, and over 340,000 people die from diabetes and related complications each year. The COVID-19 pandemic has worsened the situation as the public health measure and disruptions in essential health services have meant that people with diabetes might not be able to access the health care they need to optimally manage their condition. This year, as we celebrate the 100th anniversary of the discovery of insulin, many individuals still struggle to have access to this medicine in our region, as well as the basic technologies for diabetes management, such as blood glucose meters and test strips. Furthermore, many people with diabetes remain undiagnosed due to a limited access to primary care services for diabetes care. So we have still many people in our region that they have diabetes, but they don't have access to primary health care in order to be diagnosed and to start receiving the treatment. So on this day, PAHO joins its partners to draw attention to governments and global health actors on the need to improve access to health services, medicines, and supplies for the diagnosis, treatment, and self-management of diabetes. These inputs are critical to control diabetes, prevent its complication, and improve the quality of life of people living with diabetes. Every country must ensure that diabetes care remains accessible and is incorporated as part of the primary care services network. This may mean offering care outside of traditional settings or relying on community health workers to conduct outreach services. In addition, insulin and other essential diabetes medicines must remain accessible and affordable to those who need them. In this regard, I want to urge governments to make use of PAHO's strategic fund, which offers high-quality diabetes medication at optimal prices, regardless of purchase size, because of its pooled regional procurement mechanism. Our health professionals must ensure that people with diabetes understand their risks and have access to the information and tools to manage and monitor their condition. To support these actions, the Global Diabetes Compact was launched by WHO earlier this year to unite the global health community to improve diabetes care. PAHO is committed to implement the Diabetes Compact in our region and to provide the technical cooperation to our member states. Please join us in raising awareness and in expanding diabetes diagnosis and treatment services as part of our efforts to build stronger and more resilient health systems in the Americas. Thank you for your attention, and let us now proceed with the World Diabetes Day webinar.
Excellent. Thank you very much, Dr. Barbosa, for this very inspiring message and for reminding us that diabetes services must be part of primary care services. And if you've just joined us, that was Dr. Jarvis Barbosa, the Assistant Director of the Pan American Health Organization, providing the opening remarks for our webinar on diabetes. And now we will turn to start our program, which includes an outstanding group of experts and practitioners from across the region who will talk to us about their experiences in improving access to diabetes in various contexts. But before we begin by going through the country experiences, we're going to start by first providing an overall context for diabetes in the entire region of the Americas. And for this, I'd like to invite our department director, Dr. Anselm Hennis, who leads the program on non-communicable diseases and mental health here at the Pan American Health Organization. Dr. Hennis, talk to us about diabetes situation and challenges and PAHO plans, please.
Good morning, all. Thank you so much for those kind words, Savannah, and welcome to World Diabetes Day and this webinar. So if you can put up the slides, Savannah, we think we can make a start. Thank you so much. Let's put it on slide presentation mode. It's still on. Wonderful, wonderful. So as we all know, diabetes is among the leading cause of death in the Americas, and it is actually the 6th leading cause of death, accounting for 20.9 per 100,000 in terms of the mortality rate in the Americas. Let's go to the next slide. Now, as we also know, and as Dr. Barbosa said, 62 million people have diabetes in the region, which is an overall regional prevalence of about 8.3%. It's important to note that the diabetes prevalence rates are highest in the Caribbean countries. And in fact, to really give a context, 9 of the 10 top countries which are listed with prevalent diabetes are in the English-speaking Caribbean, or 13 of the top 15 countries also are in the English-speaking Caribbean. So a small region with inordinately high rates of diabetes. Women are affected more than men. And also indigenous populations have about 2 to 3 times the rates of diabetes compared to general population in the United States. There are also other ethnic differences. For example, persons of South Asian descent in many of the populations, particularly in the Caribbean, have a predilection for having high rates of diabetes. Let's go to the next slide. Now, if we look at the trends in diabetes prevalence in the Americas, and in fact, the WHO Global Action Plan target is to halt the rise in diabetes. We can see from this slide that we are not on track and will not achieve this by 2025 in either gender. So we have a major challenge in our hands. Let's go to the next slide. So this is looking at global health estimates, and it speaks to changes in patterns of the major cause of years of life loss per 100,000 in the Americas. And in the year 2000, the age standardized rate of years of life loss ranked diabetes at number 10 with 520 per 100,000. 2 decades later, it's now ranked at number 8 with roughly 500 per 10 to the 1,000 years of life lost. And due to tremendous levels of disabilities and illness, diabetes is a leading cause of blindness, kidney failure, heart attacks, stroke, and lower limb amputation. And this situation has not improved with time. Let's go to the next slide. Now, why are we focusing on diabetes now? We heard already, and I'm going to say again and again, the growing epidemic of diabetes. 62 million people in the Americas live with diabetes, and as I said again, it's one of the leading causes of death. there's insufficient prevention. And in fact, when one does a comparison of all 6 WHO regions, the region of the Americas is the region which has the highest prevalence of overweight and obesity, as well as we are the global leader in terms of physical inactivity. They all go hand in hand. And these are drivers that tend to underpin our rates of diabetes. There's lack of diagnosis and management, again, as Dr. Barbosa said. Many people have diabetes and they're unaware or undiagnosed. And in fact, for example, in the US, as many as 1 in 3 adults or 88 million people have pre-diabetes and are not aware of it. So 50 to 70% of people who have diabetes do not have their blood sugar levels controlled. There's limited access to diabetes medicines and technologies, again, a point raised by Dr. Barbosa. And globally, 50% of persons with type 2 diabetes do not have access to insulin. In the Americas, the availability of essential diabetes medicines and technologies needs to be improved in the public sector. And I'm just going to draw your attention to a leader in this morning's Lancet, which is titled in the editorial, 100 Years of Insulin, a technical success, but an access failure. And they speak to the fact that, that in spite of the gains in terms of treatments and so forth, access and cost tends to be a major barrier that continues to limit diabetes management and adequate access and care in this day and age. So these are major issues for us to tackle, and we've also heard about the WHO Global Diabetes Compact, which is now potentially proving a route and an opportunity through its bringing together private and public sectors to work on these 3 main areas: improving access to insulin and accompanying diabetes treatment products, building resilient health systems, and as well as involving those living with diabetes in the conversation as the way forward. Let's go to the next slide. Thank you. World Health Assembly Resolution of 2021, strengthening the prevention and control of diabetes, raises the priority given to diabetes within the non-communicable disease responses. It raises awareness about the burden of diabetes. It makes the case for including diabetes treatment and care in domestic COVID response and recovery plans. And as you've heard, of the tremendous adverse impact of the pandemic on our health system services and the higher rates of complications, et cetera. And the need to strengthen health services for improved diabetes care. And as you can see, through prevention, early diagnosis, treatment and care, information, access to medicines and technologies, improved health management information systems, and equipping care through an adequate and well-trained workforce. Next slide, please. The new WHO report on insulin access speaks to limited availability. 3 multinational companies control more than 90% of the insulin market. Globally, half of people needing insulin for type 2 diabetes do not get it. And 60% of insulin availability is in Europe and the United States of America. But 75% of people with diabetes are outside of these areas. So right where there's a geographical and geopolitical mismatch in terms of where of availability and need and access. Prices in the United States of America, prices of insulin are 6 to 9.5 times higher than other high-income countries, which limits accessibility and availability. Quite often, you may have access to insulin, but you cannot have access to strips for monitoring. In Mexico, over half of annual household income goes to managing type 1 diabetes for households which are so affected. Next slide. We have looked at the country capacity for diabetes control in the Americas. You can see the figures here. Over half have an operational diabetes action plan or strategy. Just fewer than a half of countries have national diabetes targets. Blood glucose measurement supplies are available in 94% of countries, HbA1c tests in 54%, and population surveys to measure diabetes in about 1/5. So we have some issues where we do well. Essential managed medicines for diabetes available in 70% of countries, and guidelines exist also in about 74%. So you can see some of these gaps are tremendous and can be addressed and filled, but basically in sum, we have a long way to go. Next slide. So what is the global diabetes impact? As I said before in my brief introduction, it speaks to strengthening prevention and awareness through obesity prevention plans of action, information, education, communication, as well as mobilizing communities. Another pillar is diagnosis and treatment. And one of the very interesting opportunities is through the diabetes module of the HEARTS initiative, and I'm sure you know much about it. That's another conversation for another day. Also building capacity of providers. And as we said before, the PAHO Strategic Fund allows access to pool procurement for many of these medicines and technologies that can transform the way that we can provide access and care for diabetes in terms of insulin, other medications, including sulfonylureas, as well as technologies such as glucometers. Monitoring, there are different mechanisms to, for example, population-wide step surveys and other health information systems. Next slide. These are, in the PAHO Strategic Fund, there currently exists these types of insulin, soluble, intermediate acting, as well as metformin and glycoside. But we have to really facilitate country uptake of these medications and expand the scope. There's just not enough uptakers yet. And the use of these PAHO Strategic Fund can result in tremendous cost savings and increased access, coupled with technical cooperation. Next slide. What's the way forward? We posit that an increased uptake of the PAHO Strategic Fund for Diabetes Medicines and Technologies would tremendously advance the access and reduce the treatment gaps in the region of the Americas. There's need to intensify advocacy and communications to raise diabetes awareness and to empower people living with diabetes who really must have a voice at the table in the planning and implementation and the monitoring and evaluation. There's need to scale up the implementation of diabetes prevention and control interventions in primary care through the HEARTS package as we strengthen the management and implementation and integration of non-communicable diseases in primary care. We must strengthen surveillance and information systems for diabetes, inform policies and practice, and also foster multi-stakeholder partnership in diabetes at the local, national, and regional levels. So really a lot to do. And I think at this point in time, Silvana, I hand back over to you.
Thank you very much, Dr. Hennis. That was Dr. Anselm Hennis, the Department Director for Non-Communicable Diseases and Mental Health at the Pan American Health Organization, giving us a tremendous overview of the diabetes situation in the Americas region and highlighting that while we're into 100 years of having insulin available, it's still a problem of access. And then, of course, also highlighting that it's not just having the medical technologies like medicine to be able to treat people with diabetes, but it's having that whole health service organization delivery to be able to have people diagnosed early and in time, receive the treatment, follow-up care that they need, and to be able to monitor and survey people and prevent complications from diabetes. And we know this is a tall order to ask of health systems, particularly at this time where COVID-19 continues to ravage most of our countries and the priority for public health continues to be directed to COVID-19. But we know that many countries in our region have still continued to ensure essential services in primary care. Tackling people with diabetes and addressing their needs has been part of the health system work. So here to showcase some of these experiences, we've invited some of our colleagues from the Ministries of Health. So we're going to start with our first country representative from Paraguay, and I'd like to invite Dr. Doris Roig, who is the director of the diabetes program in the Ministry of Health of Paraguay, to talk a little bit about her experiences. Doctora Roig, over to you. Doctora, no podemos escucharte. Tu micrófono está cerrado.
Muchísimas gracias.
Sí.
Gracias al comité organizador de la Organización Panamericana de la Salud. Y bueno, realmente me voy directo al punto de cómo fuimos generando pasos para el acceso a la atención de diabetes en el Paraguay. Paraguay tiene algunas características muy interesantes en relación al acceso. Principalmente, vamos a la presentación en sí. principalmente relacionado a lo que significó nuestra historia desde 1994. ¿Cuándo comienza la historia de Paraguay? Comienza con un programa, que es el Programa Nacional de Diabetes del Ministerio de Salud Pública, que se crea en 1994, y hay un impacto importante siguiente, un impacto importante que tuvo nuestro país es el comenzar a trabajar en el modelo de cuidados crónicos. Me quiero organizar en la presentación desde el modelo de cuidados crónicos. Yo creo que nosotros no podemos ver más la diabetes si no vemos al paciente en forma integral con todas sus patologías asociadas, con sus patologías crónicas asociadas. Y en ese modelo de atención estamos recién desde hace unos 5 años, pero en la realidad, acá el siguiente, lo más importante que yo quiero transmitirles a ustedes de los pasos que fuimos haciendo para acceder es el siguiente, en el sistema de entrega de servicios, este punto que es muy importante. Tenemos, nos quedamos aquí en unos minutitos como para poder explicarles dónde estamos. Estamos en un proceso de implementación. Paraguay tiene un 35% de cobertura de atención primaria. Eso nos marca mucho. Ese 35% de cobertura de atención primaria significa que recién en ese 35% podemos comenzar a trabajar en lo que significa la derivación en los diferentes niveles de complejidad, en mejorar la calidad de atención en el siguiente nivel de complejidad y en realmente respetar la cartera de servicios del primer nivel. Tenemos una guía de manejo que fue consensuada con todas las sociedades científicas, y esta guía, independientemente de lo que es consensuar un manejo en relación a diabetes tipo 1, diabetes tipo 2, diabetes y embarazo, en el manejo de la consulta nutricional, tiene un dato muy importante que es este score de clasificación de pacientes. Quiero compartir con ustedes lo que significó este impacto de generar un score de clasificación de pacientes con diabetes. En las comunidades, en los departamentos donde tenemos 100%, 70%, en la realidad no tenemos ningún departamento con el 100%, pero que nos acercamos a un 100% de cobertura de atención primaria, permitió que de 1.200 pacientes que estaban siendo atendidos en el segundo y tercer nivel de complejidad, los pacientes, al ser clasificados según su complejidad, pacientes con diabetes tipo 1, pacientes con diabetes y embarazo, las pacientes con diabetes y embarazo, o pacientes con diabetes tipo 2, complicados con alguna complicación o con un mal control metabólico o baja adherencia al tratamiento, eran los pacientes que quedaban en ese tercer nivel, y todos los demás pacientes que estaban con baja complejidad, con pocos años de evolución o con tratamiento con medicación vía oral o 1 o 2 dosis de insulina, quedaban en el primer nivel. Este score nos permitió organizar y mejorar la presión asistencial en el siguiente nivel, y mejorar la calidad de atención, y eso hizo que, por ejemplo, en departamentos donde había 1.200 pacientes, 200 queden en el segundo nivel y 1.000 sean distribuidos en las diferentes unidades de salud de la familia, que es lo como les llamamos al primer nivel de atención. Siguiente. El otro punto siguiente, en relación, es la información, es el sistema de información clínica. Y aquí hemos generado algunos pasos interesantes que también creo que es algo que es importantísimo compartir con ustedes. Nuestro registro nacional siguiente de pacientes con diabetes. Hemos avanzado recién en este poco tiempo en la informatización de nuestro sistema, las fichas clínicas electrónicas. Tenemos en este momento un sistema de información clínica siguiente. Un sistema de información clínica, tenemos 1.600 establecimientos de salud. Solamente en el 10% comenzamos a contar con un sistema de información clínica, una ficha clínica electrónica que está en sus inicios. Entonces, ¿qué buscamos para poder generar este registro? Este sistema de información tiene un ingreso al sistema de información hospitalario a través de la web. Entonces, pudimos generar en el sistema informático la función de notificación y poder notificar a nuestros pacientes con diabetes, codificándoles en E10 y en E11 y haciendo esa asignación también obligatoria de que todos los pacientes con diabetes tipo 1 sean asignados como E10 y todos los pacientes con diabetes tipo 2 con E11, como la clasificación, como dice la clasificación internacional del CIE-10. Entonces, ¿qué nos generó generar esta cobertura nacional? Nos generó la posibilidad también que no solamente los 1.600 establecimientos que forman parte del sistema de salud pública de Paraguay, sino que también los sistemas mixtos como el Instituto de Previsión Social, los privados, el Hospital de Clínicas, el Hospital Policial y Militar, que son otros subsistemas dentro del sistema de salud, puedan registrar a sus pacientes con diabetes y poder contar con una información país fiel. Este es el momento que hemos avanzado. Esta es una resolución sumamente reciente del 14 de septiembre del 2021. O sea, hemos arrancado con 2 resoluciones. Este año fue un año que generó un fortalecimiento institucional con estas resoluciones y con esta creación del Registro Nacional de Personas con Diabetes en Paraguay a través de un único sistema, un sistema informático país, al cual, como les vuelvo a decir, se puede ingresar a través de la modalidad web. No necesitamos tenerle al sistema en cada uno de nuestros establecimientos, sino podemos ingresar a través de un usuario y contraseña y notificar a nuestros pacientes bien codificados. Tenemos ya los primeros datos de lo que está significando este registro nacional. Esto nos va a permitir tener, porque como estira de la Policía Nacional a través del número de cédula de identidad de nuestros pacientes, vamos a tener los datos de georreferencia, de dónde viven, de la edad, del sexo, los datos de filiación de todos nuestros pacientes. Nos generó un dato muy importante en este momento, que era la información que queríamos tener clara en relación a cuántos pacientes en Paraguay tienen diabetes tipo 1 y cuántos tienen diabetes tipo 2. ¿De dónde nosotros qué teníamos nosotros como base? Como base teníamos un estudio de una encuesta que fue el STEPS, que se realizó en el 2011 en Paraguay, y que nos generó una prevalencia del 9,7% de diabetes tipo 2. A partir de ese dato de prevalencia, el único dato que teníamos, y no teníamos información clara de dónde, nombre y apellido cada uno de los pacientes, porque los diferentes sistemas informáticos con los cuales los pacientes ingresaban las consultas eran varios sistemas. Entonces, en este momento, y teníamos una información errada en relación a la cantidad de pacientes con diabetes tipo 1, lo que nos generaba un impacto en el presupuesto terrible, porque cuando comenzamos a ver cuántos pacientes tenían diabetes tipo 1, significaba codificados con E10, teníamos un número de cerca de 8.000 personas. Pero en la realidad, nuestros pacientes con diabetes tipo 1 en todo el sistema de salud no pasa de 1.829 pacientes en este momento. 1.829 pacientes en todo el sistema de diabetes tipo 1, lo que nos acerca a esa incidencia de diabetes tipo 1 de 1 por 100.000 habitantes año. Entonces, la primera información que estamos teniendo en este momento es el número exacto de pacientes y dónde están nuestros pacientes con diabetes tipo 1 a partir del registro nacional, que ya es una resolución y que ya está dentro de nuestro sistema informático país. Siguiente. En tipo 2 es nuestro gran desafío. Diabetes tipo 2, como les decía, con una prevalencia del 9,7, miren cómo es un gran desafío. Lo que está en rojo, ¿qué significa? Nosotros en nuestro país tenemos 18 regiones sanitarias, divididas por ejes, estas regiones sanitarias, y si, como el estudio de prevalencia se hizo en población de 18 a 65 años, vemos la cantidad de pacientes que le tenemos en este momento diagnosticados en nuestras consultas, en nuestros sistemas. Y fíjense cómo tenemos una brecha de acceso, una brecha de diagnóstico que ronda alrededor del 80-90%. En los departamentos donde tenemos una mejor cobertura de atención primaria, tenemos todavía una brecha de diagnóstico del 70%. Es altísima. en la realidad de cuando comenzaba a hacer este análisis, todavía no tenemos registro de tipo 2. Esto es lo que tenemos en relación a qué población tenemos de 18 a 65 años. Si decimos que el 9,7% tiene diabetes de esa población de 18 a 65 años, y nosotros tenemos en este momento solamente 61.000 pacientes que están así consultando. Esto es solamente en el sistema público. Aquí no ingresan los otros subsistemas. Pero simplemente en nuestro sistema público le tenemos como personas consultando en un año, en el año 2020, le tenemos a 61.000 personas. Pero si tenemos esa prevalencia del 9,7%, todavía nos quedan 351.000 personas por ser diagnosticadas o que consulten en forma sistemática. Muchas de ellas por la pandemia que no volvieron a consultar porque tuvimos momentos y años donde teníamos cerca de 90.000, cerca de 30.000 personas quizás que ya no están volviendo a consultar en forma continua y no le teníamos en el 2020 en nuestros datos. Pero la brecha es alta en lo que nos queda todavía y me asustó realmente analizar estos números así en forma clara en relación a nuestra prevalencia y a la gente que está accediendo. Entonces, siguiente. La siguiente diapositiva. ¿Cómo también hacemos? Esto también es algo muy interesante en lo que va a significar el anterior. El anterior, porque es muy importante el anterior. El anterior es cómo acceder al Registro Nacional de Diabetes tipo 2. ¿No? Porque, como les decía, 1.800 pacientes, 1.900 pacientes con diabetes tipo 1 no es difícil de registrar. Es un número pequeño que generando usuario y contraseña a través de un sistema informático y todos catalogados como E10 y haciendo otra vez una limpieza a la calidad del dato, visto que estén bien diagnosticados, no es difícil. Ahora, más de 400.000 personas, ingresarle como en el registro nacional es un número diferente. Entonces estamos viendo diferentes modalidades. Estos usuarios y contraseñas a través de nuestros coordinadores de enfermedades crónicas de cada región sanitaria y de nuestros jefes de atención primaria de la salud en las 857 unidades de salud de la familia que tiene el Paraguay, vamos a poder ir ingresándoles. Pero, como solamente tenemos 35% de cobertura de atención primaria, necesitamos ingresarle al resto del 65%, ¿verdad? O sea, es un número muy importante todavía que necesitamos ingresar. Con la pandemia, el Ministerio de Salud y Salud en Paraguay, en todo el mundo, pero en Paraguay se posicionó mucho una forma de ingreso que es el call center, un número gratuito al cual uno puede llamar y haciendo una llamada gratuita al call center puede generar el autorregistro diciendo que tiene diabetes y entonces generar a través de una línea telefónica un autorregistro. Estamos iniciando este proceso con las dos capitales, Asunción, que es altamente más de 1 millón de personas viven en Asunción y más de 4 millones de personas viven en Central. Entonces, esas son el número de personas que vamos a ir registrando también como una modalidad a través del call center. Entonces, esta es una línea gratuita que va a significar una entrada más para el Registro Nacional de Personas con Diabetes. Siguiente. Siguiente. Vamos a otro de los puntos importantes que quería compartir con ustedes como una característica Paraguay en relación al modelo de cuidados crónicos, el apoyo al automanejo. Siguiente. El apoyo al automanejo está dado también con que tenemos estandarizado una forma nuestra que es el cuaderno de nuestros pacientes, mi cuaderno de salud, que permite que los pacientes tengan como una ficha clínica electrónica portátil cuando todavía no tenemos ese 100% de sistema informático, porque el día que tengamos un sistema, una ficha clínica electrónica en todo nuestro sistema no va a ser necesario contar con un cuaderno de salud porque ese dato va a estar. Pero nuestros pacientes tienen una característica tan importante que es la característica de migrar de un servicio a otro y que de la información y toda la historia clínica del paciente se nos pierde. Esto es algo que es muy típico nuestro y que estamos logrando estandarizar y forzar realmente a que sea una condición única en todos nuestros pacientes con enfermedad crónica. Siguiente. Siguiente. Bueno, queriendo recalcar, ¿verdad?, el tema insulina y Paraguay. Paraguay tiene un vademecum, les cuento algo muy importante en lo que fue nuestra historia, porque si Banting ya hace 100 años descubrió la insulina, para Paraguay significó tener insulina recién en 1997. En 1994 se crea un programa, pero no había un presupuesto del Congreso de la Nación. Recién en 1996 se sancionó un presupuesto de alrededor de $400.000 y que eso hizo que las industrias farmacéuticas comiencen a importar y comiencen a decir, bueno, en Paraguay vamos a tener insulina y se tiene insulina disponible en el mercado y accesible desde el sistema de salud pública al Paraguay a partir de 1997. Ese presupuesto tuvo un impacto muy importante, fue creciendo hasta inclusive $19 millones al año, hasta que se crea una ley, y esa es una ley que es sumamente importante en nuestro país, la Ley de Atención Integral a las Personas con Diabetes, ya promulgada en el 2003, pero modificada en el 2014, que generó, miren lo que generó simplemente contra una ley, de $19 millones, de $400.000 inicial, que fue subiendo a $19 millones, subió en este momento a $34 millones. $34 millones es lo que nosotros tenemos en este momento presupuestado para cerca de 80.000 personas en la realidad que están accediendo al mejor vademecum. Todos nuestros pacientes con diabetes tipo 1, estos 1.800 pacientes que les dije, cuentan con insulina ultra lenta, realmente es de con insulina ultra rápida, cuentan con glucómetros y tiras reactivas. Nuestros pacientes con diabetes tipo 2, en quienes todavía falta, como del total de nuestros pacientes, simplemente el 20% está insulinizado de los pacientes con diabetes tipo 2. Nos falta mucho que trabajar, pero todo tiene que ver también con este 35% de cobertura de atención primaria. Entonces, en ese crecimiento estamos. Pero el impacto de la ley en el 2014, con la modificación, hizo que en el 2017 nuestro presupuesto esté alrededor de $34 millones. Contamos con todas las insulinas análogas, contamos con metformina, con glimepirida. En la realidad eso es algo que tiene años ya de sostenibilidad, y tanto el Instituto de Previsión Social, que es un ente mixto, pero el sistema público cuenta con medicación. Con estos pasos en la implementación del modelo de cuidados crónicos, pero con algunos pasos que cuando uno ve que parece todo negro el panorama y que lo estamos haciendo mucho, pero cuando vemos que hemos iniciado pasos dentro del marco de un modelo de cuidados crónicos, donde nos queda claro que tenemos que tener datos, un sistema de información, un registro nacional, un sistema informático, donde ya tenemos datos y donde les voy a poder decir el 31 de diciembre del 2022, en la realidad, cuando tengamos los nuevos debuts de pacientes con diabetes tipo 1 en el 2022, les voy a poder decir con total certeza, esta es la incidencia de diabetes tipo 1 del Paraguay, a partir de los nuevos casos que se presenten y que ya estén registrados en el sistema informático. Y ahí vamos a seguir avanzando en información clara y vamos a tener cerrado nuestro primer registro de pacientes con diabetes tipo 2, ya con una guía de manejo y con algo característico que va a ser aplicar nuestro score de clasificación de la mano del crecimiento de la atención primaria, porque sigue siendo la transformación del sistema de salud, sigue siendo la estrategia de atención primaria. Muchísimas gracias.
Muchísimas gracias a usted, doctora Roig, y felicitaciones por poner al centro de todos los esfuerzos las personas que viven con la diabetes, ¿no? Y felicitaciones también por la innovación con el registro y el uso de los celulares para registrar las personas, ¿no? Porque buscando y sabiendo quién tiene diabetes, uno puede aumentar el acceso y calidad de atención para servir sus necesidades, ¿no es cierto? Así que felicitaciones y muchas gracias por acompañarnos y compartir la experiencia de Paraguay. So now we will move, gracias. Now we will move to Trinidad and Tobago, and I would like to invite Dr. Abdul Hamid, who is the General Manager for Primary Care in the North Central Regional Health Authority from Trinidad and Tobago, to talk to us about how they've been managing, especially at this time of COVID-19, to serve the needs of people living with diabetes. Over to you, Dr. Hamid.
Okay. Good morning.
Good morning.
All right, good morning. Buenos dias, bonjour, bom dia. So it is my absolute pleasure to speak to you today in commemoration of World Diabetes Day. And the theme this year, of course, is the access to diabetes care. So throughout the world, as we know, and we've been saying over and over again here, there are millions of people who are unable to access the appropriate care for diabetes. Diabetes requires simple, appropriate, timely, adequate, and sustained care to manage the condition and to avoid complications. I present to you today the experience of Trinidad and Tobago and how multiple dimensional solutions can facilitate appropriate access to care.
Sonia? Oh, okay.
Right. So our country presentation, Increasing Access to Diabetes Care, outlined. So the overview of Trinidad and Tobago, diabetes prevalence, our national strategies, and our RHA specific strategies, COVID-19 and diabetes, and lessons learned and conclusion. If you notice on the map there, we are the southernmost Caribbean nation, English-speaking island. And if you notice on the map on the left-hand side, that is the tip of South America, which is Venezuela. So we are literally on the edge of the South American continent. It's a twin island republic. It's the most industrialized island in the Caribbean. Population 1.34 million. Male to female ratio of 1:1. Very, very diverse population in terms of ethnicity, religion, and culture. And it's recognized by the World Bank as a higher income economy. So our health system is guided by the Ministry of Health, and that the Ministry of Health provides leadership, governance, set policies, legislation, goals, and targets. And in our small twin island country, we have 5 regional health authorities, and they are all semi-autonomous bodies for delivery of services. They are known as Northwest Regional Health Authority, North Central Regional Health Authority, Eastern Regional Health Authority, Southwest Regional Health Authority, Tobago Regional Health Authority, and they are all defined on geographical boundaries. They are semi-autonomous, meaning that each one can develop customized approaches or initiatives, which are eventually replicated at best standard across the board. We in Trinidad and Tobago have free healthcare service for every single citizen. We have a network of 98 health centers and 7 district health facilities, 8 hospitals, and all regional health authorities have at least 1 district health facility and 1 referral hospital. So as mentioned before, Trinidad is no exception, and it has one of the highest prevalence of diabetes in the Caribbean. Some sources estimate we have at least 102,000 to 145,000 diabetics. The adult population in Trinidad and Tobago is 982,000. And we're looking at a potential cases of 121,300 diabetics. And based on the PAHO NC at a glance report, the death rate is amongst the highest, which is about 115 per 100,000 persons in Trinidad and Tobago. So we do have a very serious situation here. The diabetes prevalence in Trinidad and Tobago compared to the world and North America and the Caribbean, it's quite high amongst and across the age groups, as you can see. So given that backdrop of what we are facing and echo the previous speakers before, we in the Caribbean and Trinidad and Tobago, we have developed and had the privilege to develop certain country strategies, of course, guided by international best standards. And I was very pleased to hear it mentioned here in the symposium so far of the HEARTS D package. This has been adopted by Trinidad and Tobago Ministry of Health since September 2020. And in a similar manner to hypertension, what our approach is in terms of the HEARTS D package would be to harmonize it with the latest protocols that we have and standardized management of diabetics or diabetes, thus ensuring diabetics get standard treatment whatever site they visit. It was piloted with Tobago Regional Health Authority, and it has been in the process of being adopted at that RHA as well as the North Central Regional Health Authority and the other RHAs. Now, what is important about this, the HEARTS D package, and I think one of the reasons why we have been successful, especially with the very quick adoption of the HEARTS initiative and integration into our healthcare system, the HEARTS D package has been quite well received across the board. So our strategic intention, it's been done by a process of dissemination into clinical areas, followed by field discussions and eventual implementation across the board. Next strategy, and this was done since 2018, it's the Diabetes and Pregnancy Guidelines. So it's a major program launched in 2018 under the Directorate of Women's Health, and it standardizes the screening. It standardizes the screening of all women for gestational diabetes and provides follow-up care and management of women to prevent or control gestational diabetes. So this is one of in a similar vein, it gives a standardized routine and universal approach to screening of all antenatal patients for hyperglycemia in pregnancy and a standardized management across the board. And this is one of the important points of access to care. So not just access to care, but access to standardized care across the country. The diabetic retinopathy screening services was piloted at one of the Southwest Regional Health Authority for the past 7 years. As such, the Ministry of Health and PAHO has been implementing it across each RHA throughout Trinidad and Tobago. It is one of those initiatives that removes or takes away from tertiary care the patient having to go to tertiary care services rather than visit the primary care services to get basic screening for retinopathy. And it's been done by non-specialized retinal photography and grading. This, in effect, has reduced number of patients at tertiary ophthalmology clinics and facilitates primary care, patients in primary care getting early and easier access to appropriate retinopathy screening. As a national program, and this was done in 2017, and as a start to a national ban on sugar intake in adults on guidelines to reduce sugar intake in adults and children. Based on the WHO guidelines, there was a ban on sugary drinks in schools starting from 2017. This is in effect, given that we have, as mentioned before, Trinidad and Tobago and the Caribbean has one of the highest obesity rates in the world. And we are, with the data, we are well aware that the obesity does not just start in adulthood, but it starts at the children and the teenage levels in schools. Now, this is the Chronic Disease Assistance Program, or CDAP. It's one of our long-standing in Trinidad and Tobago access to medications. And this is a free prescription drugs program. It was established in 2003. It has an expanding distribution network of prescription drugs and medical supplies via over 200 private contracted pharmacies. This ensures true universal access to medication. So literally, citizens can access within almost walking distance a point to get medications which are free. All citizens with NCDs are eligible regardless of age, income, or other socioeconomic factors. And coverage for 12 chronic disease conditions with 47 core essential medications. Now, very important, and in the gist of our presentation here today, in that same program, one of the initial parts of the program was to supply insulin needles, oral diabetic medications, and free glucometers and strips to all diabetics in Trinidad and Tobago. And no co-payments or contribution will have been ever required by beneficiaries. In line with further community support, the Chronic Disease Self-Management Program, which seeks to empower people with NCDs to make healthier lifestyle choices and better manage their own chronic conditions. So basically, the program is to help persons develop knowledge, skills, and confidence to care for themselves and manage their condition effectively. One of the points about this program really is to have a motivated patient who has self-ownership of their health rather than reliance on the healthcare system. It is considered a key aspect of the chronic care model, and it's based on self-management and peer management. It's linked to the formal health system through established chronic disease patient support groups. And the training of lead trainers completed in June 2021, and rollout in communities started in September 2021. 72 persons to be trained by December 2021 with 6 weeks program done via Zoom in groups of 12. Multi-sectorial collaboration, and this is all in the theme of increased collaboration between the healthcare system and the public civil society. So it's the participation of civil society into the healthcare system, and it allows us to catalyze the development of healthy public policies. For example, the Diabetes Association of Trinidad and Tobago implemented a diabetes education program for primary school students. The TNT NCD Alliance facilitates greater participation by civil society sector in taking actions to reduce the burden of NCDs in the population. And they all help to increase our screening in the public sector and in the population. Plus, we have formal partnership with faith-based organizations such as the North Central Regional Health Authority, Walk the Talk, faith-based organization partnership, which seeks to both highlight healthy practices and screening in the public setting. The aim really of the healthcare system is to blur the line between the healthcare system and communities, and empowerment of communities and advocates in our communities. So here I present some of our NCRHA diabetes programs. The first major program that we have is the Diabetes Wellness Center. Now, it may seem an interesting concept to involve a tertiary care system into a primary care system, but the whole point of it is to have an innovative one-stop shop solution to bring high quality and cost-effective healthcare to treat and minimize the effects of diabetes. At that first visit, it may also be the only visit. Medical care, lab tests, pharmacy, wound care, endocrinology, nephrology, diabetic education, and ophthalmology are all done on the same patient on the same day. The whole point of it is to have a fully packaged patient, either a newly diagnosed diabetic or an uncontrolled diabetic, to have a full gamut of services to be stabilized and sent back to primary care for follow-up. It is not meant to be a regular chronic disease clinic. The whole point of it is to fast-track certain tests and assessments backwards into primary care. The other point of it is to have, now, most of the time when a diabetic is newly diagnosed, certain tests and certain assessments could take months, could take years in the regular system. So this whole program really fast tracks the patient and provides a very well-controlled patient and a motivated patient so that we will prevent any further complications. The wound care clinic in primary care, which really is increased access to timely wound assessment and podiatric service for diabetics. Traditionally, wound care clinics were, number one, not very specialized, routine, just change of dressings, and referral to hospital for further management of wounds. However, what we discovered, because of the situation in primary care and the ease of access to specialized wound care, it was realized that a wound care clinic in primary care with specialist level clinic staff would be a necessity. And we have seen potentially less amputations due to proper and timely wound care by expert nursing personnel. The diabetes support group, it's one of the important things of our diabetes or any support group is to have that buy-in by peers in the group itself. And it creates an environment where clients are equipped with the knowledge and skills necessary to make informed decisions in the management of their diabetes in an effort to achieve and maintain control of their glucose levels. So what you're in fact creating is a self-managed patient. These groups are administered by diabetic nurse educators and managed by patients. It's also our main source of motivated patients who are being trained as self-management champions and community advocates. And this is where we will get the buy-in from the public. COVID-19 and diabetes. So one of the problems, as we all have faced in the beginning of the pandemic, the first thing that happened was a complete access block. So we had problems with delivery access, efficiency, and continuity in the face of the pandemic. The very high risk, especially diabetics, suffer from poor outcomes, but they're even higher risk by being exposed to one, crowded clinics, limited access to medications, limited access to consultations. So telemedicine, as in the rest of the, eventually the rest of the Caribbean and the world, was piloted in some of our chronic disease clinics. And it started off quite basic with just a phone call, followed by a complete comprehensive consultation, counseling, renewal of prescriptions, and a special system whereby prescriptions were fully packaged and delivered to patients. So lessons learned and conclusion. So it is critical for universal clinical management approach. It is critical for a unified approach amongst all healthcare workers, amongst all primary care physicians, literally given the same message, treating the patients similarly with the same protocols and having the same standards of care across the board. There must be a recognition that the whole of society approach is vital with a very strong community partnership. And as I mentioned, blurring that line between healthcare, formal healthcare, and the communities. and most important, continued access to appropriate care despite challenges of the COVID-19 pandemic. I thank you so much. These are some scenes of my country, Trinidad and Tobago.
Wonderful. Thank you very much, Dr. Hamid. And congratulations on having such a very comprehensive program that addresses primary prevention of type 2 diabetes and prevention of complications from uncontrolled diabetes, to having a very complete wellness clinic for people and standardization of care through guidelines that are applied across all the regional health authorities. And also on telemedicine, which I think is the way of the future, right, to ensure continuity as we face health outbreaks. And so thank you again for sharing your insights and experiences. And we're going to move now to the panel of our partners from the International Diabetes Federation. And I'm really pleased that we have the regional chairs from our region who are going to talk about civil society perspectives on improving access to diabetes and engaging more closely with communities and people living with diabetes. So I'd like to invite our next speaker, Dr. Douglas Villarruel, who is the regional chair for South and Central America on increasing access to care for indigenous communities in Bolivia. He will present in Spanish, and just to remind everybody that there is simultaneous interpretation at the bottom with the interpretation globe at the bottom. Over to you, Douglas.
Muchas gracias. Quiero hacer un agradecimiento muy especial a Silvana Luciani y a Beatriz Yáñez por el fenomenal trabajo que están haciendo, y junto a todo ese maravilloso equipo de OPS y de IDF para el trabajo conjunto de ambas organizaciones en el afán de levantar la voz de la diabetes y de expandir nuestras acciones de manera conjunta. Muchas gracias, Silvana, por todo tu trabajo. Bueno, vamos a empezar a comenzar a hablar sobre un caso muy específico y que tiene que ver sobre el acceso al cuidado de la diabetes en una comunidad indígena en Bolivia. Siguiente, por favor. El Centro Médico Susan Ho se encuentra en Palacios, Bolivia, que está a 110 kilómetros de la ciudad de Santa Cruz de la Sierra. Fue fundado gracias a las iniciativas y aportes de la doctora Susan Ho, que falleció hace un par de años, y mi persona. Siguiente. Trabaja en comunidades rurales, con comunidades indígenas. El Centro Médico de Palacios se encuentra en Santa Cruz de la Sierra, en la zona del Amazonas. Si ustedes ven, para ubicarse en el mapa, arriba en la altura está La Paz, el lago Titicaca y Machu Picchu de Perú. Siguiente, por favor. Bolivia tiene 4 altitudes contrastantes. Tenemos el alto que está a 4.500 metros y luego vamos bajando hacia La Paz a 3.649 metros, Cochabamba, que está más bajo a 2.500 metros, y finalmente Santa Cruz, que está a 437 metros, que es donde se encuentra nuestro centro que trabaja con las comunidades indígenas. Siguiente, por favor. En el único estudio de prevalencia de la diabetes que se hizo en 1998, con el apoyo justamente de la Organización Panamericana de la Salud, observamos que la prevalencia de la diabetes en Bolivia era del 7.2% y que conforme bajamos desde la altitud al llano, la prevalencia de la diabetes iba aumentando del 2.7% al 10.7% en Santa Cruz. Siguiente. El Centro Médico Susan Ho brinda atención de salud primaria a las personas de comunidades indígenas que se encuentran en la selva tropical boliviana a 110, 120 kilómetros de la ciudad de Santa Cruz. Da atención de calidad para enfermedades agudas y crónicas, poniendo énfasis especialmente en la diabetes, en la hipertensión y en el sobrepeso. Ayuda a los comunarios a reconocer y eliminar las causas fundamentales de sus enfermedades. Siguiente. Las enfermedades y las infecciones tropicales son lo más común que vemos en el centro médico, y entre ellas también tenemos a la desnutrición, a las infecciones parasitarias Y de todas las infecciones, las más comunes que vemos, tenemos a la enfermedad de Chagas, a la malaria, dengue, a la fiebre amarilla, leishmaniasis, tuberculosis y VIH, que son de lo más prevalente que vemos en el centro. Siguiente. La clínica, como les decía, se encuentra alejada de la ciudad de Santa Cruz de la Sierra. La mayor parte del camino es pavimentado, pero tenemos los últimos 10 kilómetros donde todo el mundo lo conoce como el camino feo, porque cuando llueve es difícil de llegar, puesto que estamos en un lugar en donde tenemos nuestro propio internet satelital, nuestro propio sistema de agua, nuestro propio cableado para llegar, para tener luz eléctrica, un pozo para sacar agua porque no llega al lugar. Y atendemos 14 comunidades indígenas o rurales y para llegar cuesta, pero nosotros ayudamos con el transporte para las comunidades. Siguiente. A veces los médicos tienen que conseguir su propia comida para la cena. Aquí vemos al doctor Michael Angeron de la Universidad de Northwestern en Chicago, cuando vino a apoyar a nuestro centro y se encontró en el camino con este armadillo que comúnmente se lo llama tatú. Siguiente, por favor. En el centro médico atendemos, ponemos vacunas a los niños, se atiende comunidades que se encuentran más hacia el norte del centro donde hay mucha inmigración, se atienden enfermedades crónicas como artritis deformantes o lesiones de las piernas ocasionadas por neuropatías y neuropatías diabéticas. Siguientes. El equipo en el centro, tenemos entrada de datos de sistemas médicos electrónicos, tenemos la farmacia, el laboratorio, un servicio dental, oftalmología con lámpara de hendidura, y bueno, damos servicios de lecturas de rayos X en las ventanas, que es igual de eficiente. Siguiente, por favor. Recordemos que todo esto lo hacemos en comunidades rurales, en un ambiente tenemos una clínica que está alejado de las poblaciones. Observamos mucho lo que es la paradoja de la nutrición, en donde hay bajo peso y al mismo tiempo obesidad, es decir, alimentos baratos con muchas calorías, muy bajos nutrientes, que afectan el crecimiento de los niños y por lo tanto, de tantas calorías los lleva al aumento de peso. Cuando consumen calorías en exceso los lleva al aumento de peso cuando antes han tenido el bajo peso, y eso debido a un efecto del cuerpo de guardar calorías puesto que antes han estado en carencia. Siguiente. Entonces, el manejo de la diabetes que damos en una comunidad rural, amazónica, es obviamente diferente que en cualquier centro de salud que tiene las condiciones en una ciudad. Nuestros objetivos principales son lograr que los niveles de azúcar sean lo más cercano lleguen a lo más cercano a lo normal posible, que no haya bajones del azúcar, y con todo esto tratamos de disminuir las complicaciones tanto microvasculares, neurológicas y macrovasculares de la diabetes. El 98% de las personas que tienen diabetes es de tipo 2, y la atención que damos está centrado en la prevención primaria, en la intervención secundaria, y tenemos una capacidad limitada para realizar lo que es la intervención terciaria. Por ejemplo, cuando alguna persona se infarta o le da un accidente vasculocerebral. La siguiente. El manejo de la diabetes a nivel de prevención primaria está centrada en los cambios de estilo de vida. Promover el ejercicio, promover la alimentación saludable. Pero la pregunta que siempre nos hacemos es, ¿cómo lo implementamos a gran escala? Siguiente. Y bueno, vemos que la cultura de muchas comunidades rurales enfatiza hábitos menos saludables, pues, donde las personas ingieren comidas llenas de grasa y especialmente llenas de carbohidratos. De mismo modo, hacer ejercicio con regularidad es menos común en las comunidades rurales, especialmente en las comunidades más pequeñas. Siguiente. Hay más énfasis en disfrutar las cosas, como la comida, que pensar en las consecuencias para la salud dentro de 10 años. Muchas personas en las comunidades que nosotros atendemos no tienen fácil acceso a productos frescos tampoco. Y esto ocurre a pesar de que la agricultura es parte de las actividades de trabajo de todas esas zonas. Siguiente. La falta de educación es más común en la mayoría de las personas que viven en estas 14 comunidades rurales que atendemos, y sabemos que sin la educación adecuada sobre la salud en general, es natural que prevalezcan los hábitos poco saludables. Es por eso que hacemos mucho énfasis en la educación. Y a pesar de que el trabajo en el campo es duro, vemos que las personas realizan poco o nada de actividad física o de ejercicio propiamente dicho. Siguiente. Tenemos programas que desarrollamos en cada comunidad rural y uno de ellos son los programas comunitarios de actividad física, haciendo lo que a ellos, promoviendo lo que a ellos les gusta hacer. En este caso, por ejemplo, son las danzas típicas de cada comunidad. Es una forma súper agradable e interesante de promover las actividades físicas en las comunidades. Siguiente. De la disponibilidad de medicamentos en Bolivia, pues no hay muchas opciones. Lo que más usamos y es la piedra angular de los tratamientos en nuestro centro es la metformina. También tenemos disponibles la sulfonilurea, especialmente la glibenclamida con mayor abundancia. Tanto las tiazolidenodionas como los inhibidores de DPP4 los tenemos en Bolivia, pero son caros, no podemos acceder a ellos para ofrecerlo a las comunidades, puesto que nosotros proveemos los medicamentos de manera gratuita o en algunos casos con muy bajo precio. Los agonistas de GLP-1 no están disponibles, los inhibidores de SGLT2, que son tan buenos para las personas con diabetes, no están disponibles. Hay insulina NPH regular, glargina, pidra en Bolivia, pero obviamente las que usamos son las de menor costo, que es la NPH irregular. Siguiente. En lo que respecta al manejo de la diabetes en la intervención secundaria, el control de la glucemia es la base. Los medicamentos que usamos, como le comentaba, es la metformina y la sulfonilurea, como la glibenclamida, y la insulina proveemos insulina, pero realmente es bien difícil manejarla, puesto que es necesario, muchas veces no tienen dónde refrigerar y lo que promovemos es que haya un refrigerador comunitario. Luego hay condiciones muchas veces insalubres para las inyecciones. Muchas casas no tienen pisos, los pisos son de tierra, duermen en el piso, entonces es complicado. Las personas con diabetes vienen al centro mensualmente para medir sus glucemias en ayunas y presión arterial. Muchas veces el control de la glucosa en el hogar no es realista, puesto que se echan a perder sus aparatos, no tienen suficientes reactivos, a veces le regalamos, a veces no. La medición de hemoglobina A1C se hace cuando tenemos reactivos. Los reactivos del DCA2000 que hay en nuestro laboratorio son caros, así que no podemos usarlo con todos. Y ajustamos los tratamientos para alcanzar mínimamente un 8 de hemoglobina glicosilada, sabiendo que lo ideal es que sea menos de 7, pero es difícil lograrlo, debo aceptarlo. Siguiente. Con respecto a la intervención secundaria, ¿cómo hacemos para que no terminen con una amputación? Bueno, control de las glucemias, esa es la base. También el examen de la pérdida de sensibilidad mediante la vibración y el monofilamento. La prevención de heridas, insistimos que usen zapatos, que no usen sandalias, abarca, que no anden descalzos y tratamos de que los zapatos no sean ni muy apretados ni muy grandes. Y bueno, cuando vienen con úlceras del pie, tratamos siempre de hacer un tratamiento conservador porque luego no van a tener recursos para si terminan en una amputación y su vida se les va a hacer tremendamente difícil. Con respecto al daño de la diabetes en los ojos, control de glucemias, tenemos provisiones de lente que muchas veces nos da el Club de Leones y bueno, no podemos realizar fotocoagulación con láser porque no hay ese procedimiento, no lo tenemos y no hay en las comunidades rurales, hay que venir a una ciudad grande. Siguiente. Tampoco hay endocrinólogos en las áreas rurales, entonces muchas veces quienes toman su lugar son curanderos que no siempre hacen un buen trabajo. Entiendo que nosotros hemos hecho incluso un estudio de las plantas más comunes que utilizan para tratar diversas enfermedades, especialmente crónicas, para entender un poco a las comunidades indígenas qué es lo que entienden como un tratamiento, pero luego observamos las complicaciones por falta de la atención. Siguiente. Y la falta de educación, la falta de acceso a los médicos, el hecho de que no haya endocrinólogo hace que muchas de las complicaciones avancen o que no hayan especialistas en diabetes o incluso acceso al cuidado de la salud en general, hacen que aparezcan las complicaciones de la diabetes. Y bueno, el costo de los cuidados cuando van a un centro médico es prohibitivo porque no es que sea gratuito en otros lugares. En nuestro espacio es gratuito, pero en el resto no. La diabetes mal manejada los conduce a varias complicaciones que en la mayoría de las comunidades rurales no están preparadas para abordar. El pie diabético es una de ellas y avanza porque no sienten, no les duele. Entonces, los enfoques que hacemos se centran en modificación de estilos de vida que sean eficaces para que no necesiten medicamentos tan costosos para la prevención de la diabetes y de las complicaciones de la diabetes. O sea que siempre nuestra primera tarea en comunidades rurales es educar, educar, educar. También tratamos de generar información para educar a los responsables políticos de las regiones sobre la urgente necesidad de actuar en comunidades rurales. Siguiente.
2 minutos más, doctor Douglas.
Gracias, Silvana. Entonces, ¿cuáles son las barreras conceptuales para la atención a largo plazo? Bueno, que las personas comprendan el significado de tener una enfermedad crónica. Sabemos que las preocupaciones a corto plazo la abruman, no piensan, es difícil pensar a largo plazo. La necesidad para hacer controles y recibir medicaciones continuas, que es un concepto que no estaban acostumbrados. Son demasiado pobres para comprar medicamentos y hay falta de transportes. Siguiente. Y tenemos 3 pasos que implementamos. Investigamos las barreras que impiden a los programas de tratamiento de largo plazo, establecemos programas a largo plazo en las comunidades, detectamos y superamos otras barreras prácticas para la atención. Siguiente. Hacemos encuestas verbales en las comunidades para entender qué significa para ellos el término enfermedad de larga duración, el tratamiento que están tomando, qué cambios de estilo de vida han hecho. Siguiente. Desarrollamos programas sobre el manejo, identificamos Es decir, identificamos a personas voluntarias, las capacitamos para manejar de manera efectiva la diabetes. En las comunidades miden el azúcar, la presión, establecemos parámetros de derivación de sus comunidades a nuestros centros para hacer ajustes en sus tratamientos. Siguiente. Hacemos alianzas con las comunidades, les damos formación y cuando terminan su formación en salud, les damos certificados. Siguiente. Proporcionamos medicamentos gratuitos en cantidades mensuales o trimestrales. Damos tratamientos observando directamente al paciente. Damos transporte. Tenemos una red de voluntarios en la comunidad. Colaboramos en vez de competir con cuidadores locales. Localizamos y facilitamos atención médica más compleja cuando es necesario. Siguiente. Y en este paciente, ¿dónde está su refrigerador para almacenar su insulina? Teniendo en cuenta que tenemos temperaturas de entre 35 y 40 grados en el verano. Siguiente, ya acabamos. En conclusión, la asociación con los cuidadores locales es fundamental. La logística de la construcción y el establecimiento de una clínica requiere perseverancia y dinero. Se necesita una base de operaciones permanente para enfermedades crónicas como la diabetes. Y es necesario superar las barreras locales, políticas, comunitarias y personales para poder brindar atención. Siguiente. Pero ella que valga la pena. Muchas gracias.
Excelente, mil gracias, Dr. Villarroel. Y para enfatizar la importancia de llegar a la comunidad y sobre todo las comunidades que viven en poblaciones aisladas y que no tienen acceso a los servicios. Así que felicitaciones por el excelente trabajo y los logros y vamos a difundir la experiencia para que podamos expandir acceso a los servicios esenciales para diabetes. Gracias. So I realize we're getting close to the end of the webinar, so I thank everybody for their patience. We have one last presenter because we want to kind of round this off with the regional perspective and sub-regional perspective. So we're going to invite now the regional chair for North America and the Caribbean of the International Diabetes Federation, and that's Dr. Timothy Dorr, who's going to talk to us about increasing access to diabetes care in the Caribbean. So over to you, Dr. Tim.
Thank you very much. I was diagnosed with type 1 diabetes over 30 years ago in Mexico City. I was 7 years old. I'd been feeling unwell for about a month. I was losing weight, drinking a lot of water. My vision was blurry. I lacked energy and I didn't want to play. As I'd always been extremely active and alert, my parents knew immediately that something was wrong. They took me to my pediatrician and then different hospitals where I was prescribed treatments, but I did not get any better. My health deteriorated until one morning, I felt strong abdominal pain and could not raise my head or even open my eyes. I was taken back to the hospital where no one knew what was wrong. One of the doctors noticed a fruity odor on my breath. He asked my parents for permission to run a blood glucose test. I remember being out on an IV drip. I felt really tired and confused. I fell asleep. 5 days later, I woke up. Then a few weeks later, I was able to go home, but my life had changed. It was totally different. In Mexico, all people with diabetes have had issues accessing insulin at some point. Insulin is perhaps cheaper than in other countries, but only around 1 in 3 Mexicans with diabetes earn enough to afford everything required to manage the condition. My lowest point was when my husband and I had to decide whether to buy glucose strips or food. This was a testimonial from our very own Mariana Gomez from Mexico. There are many more testimonials like this about the life experience of people living with diabetes within our region. Our region is represented by only 23 countries. And I am Timothy Astor. I am a family physician, but I'm also the North American and Caribbean Regional Chair for IDF. And I will attempt to provide you with an idea of the experiences of persons living with diabetes here in our region, but in particular looking at emphasis on access to diabetes care. Let me first present to you for the first time data from our Atlas Committee from IDF, statistics on diabetes within our region for 2021. So this is information that has just come out. It's hot off the press, so you're the first ones to see it. Congratulations. I'm going to attempt to show you the information and then make a few deductions. Right. Now, as I looked at the data, which you will get because it will be available online, there are some major points that immediately jumped at me when I looked at that information. First, our region has 361 million people living with diabetes. Okay, all right. The number is expected to increase in the next 25 years. Approximately 12.2 million people between the ages of 20 to 79 living with diabetes are undiagnosed. There are 192,500 children between the ages of 0 to 19 living with type 1 diabetes, and 24,400 are newly diagnosed each year. Now, this figure was from 2021. The total healthcare expenditure on diabetes for persons between ages 20 to 79 for 2021 was $414.6 billion US. That's in our region. It's not just St. Lucia. So I don't think we have that much money anyway. The top 5 countries with the highest number of persons living with diabetes: USA, Mexico, Canada, Haiti, and Jamaica. I must declare, though, that I may not be in a position to explain all the data, but for those of you who like statistics and who like to look at information like this, you might agree with me when I say that this is very interesting. I'm pretty sure that the IDF Atlas Committee would be happy to speak to anybody who wants to get some further specifics on the data. So I'll get back to our testimonials, and I want you to take note that while the experiences of persons living with diabetes in just one country may vary based on maybe that person's economic background, maybe their location in the country, their education, it also varies widely from country to country. And the country's resources could also be permissive or restricted. This may in some way tie in with maybe the classification of developed and developing countries, possibly. There's a lot of economics with this. But in the NAC region, there is such diversity. And it would be very difficult for me to give you a general perspective of how access to diabetes care supplies and medication has really changed any specific community. But I did, in preparation for this presentation, do quite a few interviews and did some research. So I was able to compile the following about the availability in general of resources. Now, what I'm presenting to you may be completely free, may be subsidized, or may be paid completely by either an NGO or the government. Centers located within the communities, and as Dr. Via Worrell presented before, he showed you that they have these clinics that are far into the community, into the distant communities that are far from the city. So that's something that most countries try to provide: general medical clinics, specialty clinics, especially with endocrinology and food care, or another specialty, whichever is available in the country. Some countries don't have endocrinology, some do. There's the daily or weekly operation of those clinics, which allows for patients to get the care they need: nutritionist services, family nurse practitioner services, general nursing services, primary, secondary care services, access to medication testing supplies, and access to education materials and other helpful resources. Right? So all of these things are things that have been done, and the presenters before have given you a good idea of those things that are available, the great work that they've been doing to get the patients the medication and the education that they need. In some of those primary care services, you may have a few other things that are available. For instance, blood sugar and pressure testing as requested, laboratory screening, and that would include screening for your kidney function, liver function, lipid profile, the HbA1c, whatever is necessary. I'm hoping you can hear me. I saw you lean forward. All right, diabetic retinopathy screening, podiatry visits, general medical clinics, dentistry visits, dermatology consultations, diabetes and hypertension clinics, and self-management through courses, for example, Stanford, which PAHO has provided. Of course, there are many others, but we have improved. And I can tell you, there's evidence. We've been doing a lot of work, not just PAHO. There's ADA, the individual organizations in the different countries. We've all been doing quite a bit of work. And this is the fruit of our labor. You see all of this, right? But then you still hear the statistics that we have 361 million people living with diabetes, and the numbers are tending to increase, right? So we do have a problem on our hands. So, sorry, right? A patient from one of the Caribbean countries actually shared this testimonial with me. In his 30 years of living with diabetes, he felt satisfied that medication, insulin, doctor's visits, the laboratory tests for screening, all that I mentioned, and management were all free. That's right, F-R-E-E. That's something that when you hear that, you wonder, oh, how is that possible, right? And all patients who got that got it through a public government clinic, right? So you have St. Kitts and Nevis that's offering something like that, St. Lucia, St. Vincent, Grenada, Trinidad just spoke about it. So you'd find that all the countries, they're trying to adopt a model, right? And we can all understand it. This is similar to the intention that we want, which is to provide that universal health care, right? And that is certainly there. He also confirmed another thing, that the free service was reliable. He said reliable, and the supplies were available more than 90% of the time. He couldn't say 100%, being realistic. But please remember this little fact as I continue the presentation. So, in putting all of this information together and speaking to all of these people across our region, our 23 different countries, there's some things we could say that are common based on the work that we've been doing. There's an increased awareness of diabetes and its effects. Yeah, that is obvious. A lot more people know about it. A lot more people are testing, right? There is an improved quality of the self-management. A lot more people are aware of the targets and are trying to achieve those targets. So you know you're doing something good. People understand its importance, and they're willing to engage in the activities that are necessary for their own well-being. That's good. There's also an increase in the number of people who access the services. So you do have that demand growing. Yeah, so the awareness is building. Maybe we still have some ways to go, but our work is not all for nothing, right? It's not all in vain. But there are some challenges. And the challenges that I present are based on my analysis. The first one is about quality versus equity. Are you able to provide the same services to everybody? Are you willing to provide the same services to everybody? And what are the consequences? Are there people who are disadvantaged? Or are you going to try to make it equitable, where everybody receives a service where they could reach? You understand? Everybody is different. And there's another one, and this is possibly my favorite one to explain. Sustainability. Is it sustainable? Can you sustain what you're doing right now? 10 years down the line, 20 years down the line. A lot of our countries, we complain that when international organizations come in, they do a whole lot of analysis. They take data, they have you running around for weeks, and then they leave. And then what? They come the next year or 10 years later, do the same thing. What are we doing for sustainability? Or maybe our governments might decide to be proactive and do something and offer everything for free. And then they can't afford to buy food, or they can't afford to sustain other aspects of the economy. Is it sustainable? There's a lot. I don't have the answer for that, but I'm just throwing this out there. So based on those two challenges, I was able to find a few pitfalls in our access to diabetes care. Right. The first one is finance. In a paper published by Matthew C. Riddle and William H. Herman by the ADA, and that paper was called The Cost of Diabetes Care, the elephant in the room. There they described that for a long time, nobody wanted to speak about finance because they were kind of, feeling, let's just leave it alone. But it's impossible to ignore it right now because the elephant has grown so big that you literally can't be in the room anymore. All right, so they eloquently spoke about the issue in that article. And they summarized, the cost of diabetes present large problems to patients and their families, and to health systems, insurers, and the entire community. These problems are not yet coming under control, but scientific studies reported in diabetes care and elsewhere are beginning to clarify how best to limit the complications of diabetes, while both containing costs and avoiding unintended harms. This balancing act of sustainability and equity is truly difficult, I can see. And that would be the case for any country, whether you developed or developing, doesn't matter. So it appears almost impossible, as some may adopt a model which may be sustainable, and some may adopt a model which may be more equitable, while some provide equity, but it's not sustainable. So all of this, these are some of the problems. Many countries still kind of provide glucometer strips and syringes free or near free to its citizens. I kind of understand why, but I lament the fact that we can't do that. People need to test. There's an increased demand on our countries. With the increased demand, our countries often face a challenge that the majority of the people who need to test, they can't afford. So as a physician, I can tell you that treating without testing and monitoring really doesn't make sense. You're not going to achieve what you want. You're basically shooting in the dark. And it's heartbreaking to hear the testimony that I read at the start, where my patients sometimes have to choose between food and glucose testing strips. A small percentage of persons living with diabetes access medical care via the public clinic, where all these benefits exist. But there is an even larger percentage, sometimes people query, that access medical care, diabetes and medical care, through a private clinic, where they will not get all of these benefits. And this, let me be a little more specific. So this was a testimonial from a colleague of mine in St. Kitts, and you have like almost 1/3 of the people just accessing the medical care in the public clinic, and the other 2/3 are going elsewhere. What is happening to those people? How are these people getting the care they need? We're not sure. Maybe they are so wealthy they can afford it, but then that if the country is providing all these free services, Like, it would make more sense to access it there. There's still not enough involvement in our medical professionals. I know some of our medical professionals watching might probably go, oh man, I'm doing so much work already. What's wrong with you? But I'm serious. We need to endorse the message of self-management. A pharmacy colleague of mine, when we were speaking, lamented on the fact that there are persons in our countries in 2021 who still cannot test their blood sugar. This is what the pharmacist friend of mine is saying, right? And that's because they just simply can't afford the strips. It's just too expensive. Right? They have to eat, right? They can't afford glucometers, and that shouldn't be. We can do something about it, can't we? He also cited that he found that pharmacists were often left out of some of those important conversations. Like, I don't want to put any blame on our group here, but pharmacists have to be involved in even this conversation. They have to be heavily involved everywhere, because pharmacists are the ones giving patients the medication. They spend most of the time with patients, whereas a doctor will see the patients once every 3, 4, 6 months, maybe once a year. The pharmacist will see them more often because they will not want to see the doctor, but they will go get their medication. And every time, that's an opportunity for enforcing that message, for educating and for helping. So there's still more we can do, I believe. It also has to be sustainable. Some life-saving technology is only available in developed countries. We spoke about this before. I think Dr. Hennis spoke about this also. Right? You have some technology that you cannot get, you just simply cannot get because it's just not affordable. Insulin is so expensive in some countries. And then you have countries that provide it for free, but then that's all they give you. Dr. Viora gave us a list there. SGLT2 inhibitors are not available, right? Other medications are not available, but you do have some of the basics. Some patients may not do very well on those, and you need other options. And the last thing I want to mention is insurance. I did speak about insurance the last time I was here. I don't want to talk a whole lot about it because it's so complex. But insurance, what can you do? What are you doing? You're not supporting people by not covering diabetes medication and diabetes supplies for people living with diabetes who are under your insurance. What is the point? So if you're going to cover them and take the premium from them, at least see how you could also cover those supplies. Glucometer strips, you can't cover a glucometer only once in the person's lifetime because everybody knows a glucometer will never last your lifetime. You can't cover just a few strips for people who need to test so often. You can't not cover diabetic shoes or other things. I mean, I'm just throwing things out there, but you have to think about prevention. And what are you doing to prevent that person from going from that large percentage of people with risk to that smaller percentage of people with complications who are taking up the largest portion of your what do you call it? I think you call it your risk pool. So you have to think about those things. All right, this is the bibliography that I used to put my presentation together. And I think it would be remiss of me not to mention that we, in the spirit of continuing to educate, our virtual Congress in 2021, we will have it on the 6th to 11th of December. And we have a wonderful selection. We are really going to focus on complications, cardiovascular, eyes, foot neuropathy, and COVID-19. So we're hoping that people can access it. Go to our website, and we'll do the best to help. We can't stop. That's my conclusion. We can't stop. Savannah, we can't stop. We have to continue.
Yes.
No, we cannot, because imagine it's so bad and we've been doing so much work. Imagine how bad it would be if we stop. We have to continue.
Thank you. Excellent presentation, Dr. Dor, and for highlighting especially the challenges of cost and affordability, as well as access to services, and how we definitely need to do more. And we, again, are so grateful for the partnership that we have with IDF, with the civil society groups, with all the diabetes associations in our region to help make sure that together with governments, that the civil society and people living with diabetes are well represented so that we ensure that education, policies, services, services are really reflective of the needs of people living with diabetes and in the communities where they live. So I just want to thank all the presenters for such outstanding presentations and sharing your wealth of knowledge, and for inspiring us to really focus on diabetes prevention and control on this day that we're celebrating, the World Diabetes Day. And apologize to everybody for having gone a little bit longer than we had programmed, especially an apology to the translators for going longer, and to thank the translators for allowing us to be able to present in English and Spanish, and to thank everybody who has been behind the scenes from the PAHO Communications Department, from the Non-Communicable Disease Program, who've helped put this all together. And just to close off this session, I'm going to invite Dr. Anselm Hennis, our department director, to give us some parting words. Dr. Hennis, back to you.
Yes, thank you so much. Thank you, Savannah. Thank you to our presenters. Thank you to our participants. We've actually had as many as 620 people participating in this room with us today on this webinar for World Diabetes Day, dealing with increasing access to diabetes care in the region of the Americas. We've had a lot of food for thought, excuse the pun, but really we've heard a lot about the critical importance of having diabetes firmly established in terms of NCD care at primary health care level, the first level of care. We've heard about the need for multidisciplinary approaches to facilitate and speed up early detection, appropriate care, which includes self-care. And we've also heard not just about the primary care level, but as in diabetes, the need for interacting with other levels of the healthcare system, secondary care and tertiary care. And we've heard about having examples in the countries in terms of having specialists being part of the process in terms of screening and detecting diabetes patients, as well as managing their care. We've heard about the importance of gestational diabetes, not a concept we speak, not a disease area that we speak a lot about in terms of our discussions, but a critical area that we also need to strengthen our approach to. We've heard about the importance of preventing complications. We've heard about the importance of information, data. We've heard about the relevance of registries. So there's so many issues that we've heard. And we, of course, heard about the challenge with technologies and access to insulin still 100 years after the discovery of insulin. We've heard about the innovations such as the HEARTS D module, and there's so many more things that we heard this morning. And I think the key message is there's so much more to do. We all have to continue to play a role to turn the tide on the diabetes epidemic. So again, thanks to all our presenters. I wish to acknowledge from Trinidad and Tobago, Dr. Abdul Hamid. I wish to acknowledge from Paraguay, Dr. Roig. I wish to acknowledge Dr. Timoteus Storr. And I also wish to acknowledge Dr. Douglas Villarroel for the work they're doing also in Bolivia and the sub-regions. So thanks to all, thanks to our participants, and let us all go forward to do our part to tackle diabetes and halt the rise and reduce the significant toll and loss to life and disability linked to diabetes. Thank you so much for participating. Have a good rest of the day. Thank you.
Thank you.